Okay, hi, I'm Charles Mouton. I'm from the Department and Family and Community Medicine. You see, this didn't used to be our name. It used to be Department of Family Practice, but faculty meeting this week, they decided to change the name. So you're getting the first glimpse of our proposed new name change. So you have to keep that under your hat. You can't go running around telling people until we get approved. And what I'm going to talk a little bit about is hormone replacement therapy in older women. I do geriatrics in the Division of Community Geriatrics. And one of the things that comes up a lot is how do you handle and manage the problems that are associated with growing older, especially older women. Well, that is actually a recent phenomenon. If you look at life expectancy and age of menopause, back here in the 1850s, almost all the way up to this part of the century, it wasn't an issue. Most women died before they ever became menopausal. So physicians didn't have to worry about it. Now in 1950 and here the year 2000, you see almost half their life starting to be spent in a postmenopausal period. And that postmenopausal period is characterized by a woman not having the female hormone estrogen. And it's that loss of estrogen that leads to some of the symptoms that are associated with the menopause. Early on, at that age 50 or so, woman loses her estrogen bath. She starts to have symptoms associated with that early phase. It's hot flushes, problem sleeping, being irritable, having mood disturbances. You hear my old men that are married to these old aging women talk about the irritability being the big issue. Well, that's not the big issue. Part of it is just the change in aging and the change in the estrogen bath that the woman is subjected to. In addition, there's physical changes that are sort of the intermediate stage. So she's been menopausal for a couple years now. She started to have problems due to the loss of estrogen, especially in the urogenital area, namely vaginal atrophy, leading to stress incontinence, and also skin atrophy. Then later on, 5, 10 years down the road, you get to some of the more important things and what we're going to spend the bulk of the time talking about. And that's the issues of osteoporosis, cardiovascular disease, dementia, and cancer, in particular colon cancer. So I put this slide up. I usually ask a quiz, but since we're not talking to Harlingen people, we won't do the quiz part. I usually do a quiz. And the thing I asked is that, what's the leading killer of older women? Now, depending on the group I'm talking to, if it's a bunch of epidemiologists, they know the answer. They know it's coronary heart disease. But oftentimes, especially lay audiences when I talk to them, breast cancer, they all raise their hand. Okay? And people showed, if you survey the public, about 40% of women think they die from breast cancer. But the problem is that's not really the case. Coronary artery disease, cerebral vascular disease are by far and away the largest killers. And you can see the steep increase 5 to 10 years after this age 50 menopausal period. See how steeply the rates go up. Here you have lung cancer, which is actually the leading cause of cancer death in older women. Lung cancer here, and then you have breast and colon cancer on the rise. Now, what about this loss of estrogen? We talked about the big issue is one of the leading killers being coronary artery disease. What does that mean? Why is estrogen loss important? Well, looking at observational data, and these are several studies with this line here being a relative risk line of 1, everything to this side of the relative risk line, the right side of the relative risk line is saying that having estrogen puts you at greater risk for developing coronary artery disease. And everything to this side of the line means that if you're on estrogen, you're at decreased risk. And you see, by far and wide, most of the studies show a decreased risk between women who are on hormone replacement versus women who are off. So that was the first suggestion that estrogen may be playing an important role in protecting women's hearts. How is it doing it? People started saying, well, maybe we need to look and find out what's happening. Well, the biggest hypothesis, we know that it decreases mortality from observational studies by about 50%. If you look at hormone replacement therapy, it has some lipid effects, and we're going to show you some more slides about that. But that only explains about 35% of the mechanism. There are other effects, especially the effects of the estrogen that we use most commonly, and that's the conjugated equine estrogen. They have effects directly on the coronary endothelium. It affects insulin sensitivity. It causes vascular dilatation. It decreases certain coagulation factors. And it decreases the ability of the coronary arteries to take in the bad cholesterol. As far as cholesterol goes, it increases the good cholesterol, that's the HDL cholesterol. It decreases the bad cholesterol, both the LDL cholesterol and lipoprotein A, which is a subcomponent of cholesterol. In addition, it decreases LDL oxidation. If you remember, LDL oxidation is what's necessary in order for that bad cholesterol molecule to be taken up into the coronary artery vessel wall. Now this slide looks at the percent change of lipids in the various estrogens and placebo. Green is placebo, E is estrogen. This is estrogen plus medroxyprogesterone acetate given in a cyclic fashion. This is estrogen plus medroxyprogesterone acetate given continuously. And this is E plus micronized. And you can see for HDL, compared to placebo, you had increases in HDL cholesterol. That's the good cholesterol. That's what you want to have happen. In terms of LDL cholesterol, much greater decreases in LDL cholesterol. And when you're looking at conjugated equine estrogen, you will get these rise in triglycerides. Now, I need to make sure you understand that because we now think that triglycerides are in and of themselves an independent risk factor for coronary artery disease, although that was hotly debated about 3 to 4 years ago. Let's compare it to some drugs we know that are specifically designed to lower lipids and cholesterol. Again, white is conjugated equine estrogen and medroxyprogesterone acetate. Green is simvastatin. E is conjugated equine estrogen by itself. Yellow is pravastatin. And this is the combination, and this is what makes it so interesting. If you look here, hormone replacement therapy gives you about the same increase in HDL cholesterol, as well as, it's a little bit better than pravastatin actually. It's a lot better if you didn't have the progestin added to it, but oftentimes you need to add the progestin, which I will explain later. But pretty close increases, but when you combine the two, you get dramatic increases in HDL cholesterol. What about LDL decrease? Get a little bit better LDL decreases with both the statins, but not much better. But you still get significant drops with conjugated equine estrogen. And they're similar here with the combination of pravastatin with conjugated equine estrogen. And still, you can see the difference between pravastatin by itself and pravastatin with conjugated equine estrogen. You get about a 5% additional decrease in lipids. What about the new baby on the market? Now, we would talk about estrogen, I'm going to get to this at the end. Conjugated equine estrogen has some side effects. So the brilliant pharmaceutical people, when they decided to make money, they said, well, what if we get all the good parts of estrogen without any of the bad parts? So they started looking at estrogen and how it's made. They discovered some new estrogen receptors and how it works in the tissues, and they started designing what they call selective estrogen receptor modulators. And this was the first one released on the market, and that's Raloxifene. So they were looking at what Raloxifene did good that was like estrogen. Well, if you look at it, both of them, this is Raloxifene, this is conjugated equine estrogen, both of them lower the bad cholesterol by about the same amount, maybe a little bit more for conjugated equine estrogen. However, conjugated equine estrogen does a much better job at increasing the good cholesterol. That's the HDL. Raloxifene does nothing to it. However, again, conjugated equine estrogen raises triglycerides, whereas Raloxifene tends to lower triglycerides. So you have some differences, both of these being estrogens. Okay, one being a selective estrogen receptor modulator, other being, if you believe in pregnant mare's urine, is natural estrogen. So in summary, for coronary artery disease, you have some options for the older women. You have good therapeutic effects for conjugated equine estrogen, probably the same for Raloxifene. Again, we're still waiting for data on this. Statins, of course, antioxidants, and aspirin. So it has a net positive effect on the cardiovascular system. Now, again, I have to put my little caveat in this. We know this data from conjugated equine estrogens in terms of lipids. Okay? However, there's only been 2 large-scale clinical trials to look at that. The biggest clinical trial to look at that is currently ongoing, so the definitive answer on this is going to come in probably 2004, 2006 from the Women's Health Initiative. So remember, a lot of this is from clinical trials. Now, the second part you heard me talk about was the issue of osteoporosis. Now, this has been pretty well studied in estrogen replacement, and we're going to spend some time talking about it. It's a big problem. Greater than 25 million women have osteoporosis, leads to 250,000 hip fractures per year. A third of white women will fracture their hips at some point in their lifetime. 1/4 of them will fracture their spines. About 1/4 of African American women will fracture their hips. When I was a fellow, we used to think that, oh, African American women didn't have hip fractures, didn't have a problem with osteoporosis. But now that's not exactly true. You still need to be thinking about it. They just tend to have better bone mineral density in terms of amount, but they still have the possibility of having osteoporosis. Why is hip fracture an issue? Who cares? You know, you break your hip, not a big deal, right? Well, not quite. If you look at survival, you have normal survival here on the blue line. This is survival following hip fracture. You can see in the year following hip fracture, you have a 20% decline in survival rate related to that. That equates to about 20% of the people who have hip fractures dying in the year following the hip fracture. Now that's important. Those are lives that if we can prevent osteoporosis that leads to this fracture, you can do something for those women. Now this is my other question that I would have asked if we had. When is the time of a woman's life that she lays down the most bone? When does she have the best chance of preventing herself from ever getting osteoporosis? What do you think? This is late in the afternoon. We have to have some group discussion. What do you think? You can cheat. You can look at the slide and tell me. I don't mind. Well, it's in her teenage years. See, this is bone mineral density. This is age. The time when a woman's laying down the most bone mineral density, the highest bone mineral density, is in her teenage years. That's when she's being bathed, been bombarded with estrogen, right? She's becoming a woman. That's when they act crazy, right? The people who have teenage tend to act crazy, where they're having hormonal stimulation and they're just being bombarded. She's being bombarded with estrogen. So if she's going to lay down bone, she's going to do it nicely in this age group. So this is the time, if you got teenage daughters, make sure they're drinking calcium and vitamin D so that they can lay down good bone. Because she's going to pretty much stay the same between her teenage to 40s. Then she's going to go through the perimenopause and through the menopause and lose her estrogen bath and start to lose bone. Okay? Now, that's okay if she's way up here. She can lose bone all the way to here, and you can see she's not going to have too bad a bone mineral density. But what if she didn't drink her milk, or she lived in, was lactose intolerant or something, and you didn't give her good calcium, and she's somewhere down here? Okay? She loses bone mineral density, she's going to have a problem. She's going to be at risk for fractures, osteoporosis. Well, besides not drinking milk when you're a teenager, what kind of risk factors will cause you to have osteoporosis? Well, family history. If your mother broke her hip or had osteoporosis, you're at risk for breaking your hip, having osteoporosis. Ethnicity. We talked a little bit about that. If you're white or Asian, you tend to have smaller bone mineral density or smaller bones than African Americans. And so that puts you at somewhat of risk. If you went through the menopause early, okay, you need to take GRH antagonists, or you had your ovaries taken out for some reason at a young age, that means the time without estrogen is going to be a lot longer, so your bone mineral density is going to keep decreasing for a lot longer period of time, so you're likely to become osteoporotic. If you're hypoestrogenemic, this is one of the things, again, with your teenagers. if you have a teenage girl who's bulimic, she's going to be at big, substantial risk for osteoporosis when she becomes an older woman. If she's a marathon runner, she's a bulimic marathon runner, she's got big problems because she's going to be hypoestrogenic from her bulimia as well as her excessive exercise. It's going to put her at risk. Hyperthyroidism puts you at risk. And again, if she's a cigarette smoking, marathon running, bulimic, she's got problems. Well, let's look at estrogen. We talked about hormone replacement therapy. Can we do something about it? Yes, we can think about estrogen. Again, this is green is placebo, blue is conjugated equine estrogen only. I guess it's a salmon, conjugated equine estrogen with medroxyprogesterone cyclic, conjugated equine estrogen with medroxyprogesterone continuous, and the micronized progestin. You can see the change from baseline over about 3 years. You can see that the placebo group continues to lose bone. Those that were started on really any form of estrogen with or without progestin will tend to slow the loss of bone and actually gain a little bit of bone mineral density. What about Raloxifene? Our selective estrogen. Red is conjugated equine estrogen, blue is conjugated equine estrogen, white is Raloxifene, green is placebo. Over 2 years, you get about half the benefit you get from conjugated equine estrogen. So you get some benefit. So how do you manage osteoporosis? Well, all of these studies actually had people on calcium. So they need to be on calcium anyway. If they want to take and can tolerate estrogens, conjugated equine is probably the way to go because you get the best bone mineral density, plus you buy a little of the cardiovascular prevention. There's other agents like alendronate and calcitonin, which also impact osteoporosis and bone resorption. Alendronate is a biphosphonate, and this is probably true for any biphosphonate. Alendronate, etendronate, pamidronate, and risidronate is going to be coming on the market, I think, in June, he told me. All of these have pretty good increases in bone mineral density. Calcitonin and Raloxifene are probably in the same league. That's the mycalcin nasal spray. They have increase in bone mineral density. Now look at fluoride. Fluoride is actually best. Why aren't we using fluoride? Anybody have any of this? Right. What happens with fluoride, although you get the best, by far the greatest increase in bone mineral density, the studies that looked at fracture rates in people put on fluoride showed they actually had increased fracture rates. And the thought was that the fluoride was causing them to have brittle bones. Although there's now some observational studies that suggest that lower doses of fluoride, like fluorinated water supplies, tend to not cause the same amount of brittleness, and especially seeming to decrease the rate of bone loss in postmenopausal women. So there's probably going to be a push for fluorinated water systems, not just for your teeth, but also for your osteoporosis. Oh, by the way, if y'all get any questions as I go along, please shout. Well, now we've covered sort of the classic story of hormone replacement therapy. Most people, when they talk about hormone replacement therapy, they talk about the benefit for cardiovascular risk, especially prevention. They talk about the benefit in treating and preventing osteoporosis. There's some other things on the horizon, some of which are controversial. I'm going to try to talk about the controversies as we go along. The first of which is the issue of dementia and hormone replacement therapy. Dementia, while I know the women in the audience won't think so, it does become a problem as they get older, okay? Actually, men tend to get crazy less than women. That's not true. It's really probably a function of the fact there are just much more fewer men in these older age groups. So you guys didn't even react to that. Jeez. I can tell you anything. And you can see here, though, the rates tend to diverge after about age 75. Again, probably a function of them being just many more women than men. Just to remind you, dementia and Alzheimer's disease being one of the types of dementia is a neurodegenerative process of the brain that causes a slow progressive loss of mental function. Occurs in about 40% of those over age 80, about 50% of those over age 85. Affects about 4 million adults in the U.S. This, again, seems to be a age-adjusted prevalence increase in women that's a little bit greater than men. And it's the leading cause of loss of independence and putting someone in a nursing home, which you're going to hear a little bit about next. What about hormone replacement therapy and the risk of Alzheimer's disease? This is, again, observational data looking at comparison of cohort groups between women who were ever taking them versus never taking them, and versus current taking of hormone replacement therapy and the development of Alzheimer's disease. Again, this is our relative risk line of 1. Everything to this side says that if they're on estrogen, they have a higher risk of developing Alzheimer's disease. Everything on this side of the line suggests that they have a lower risk of developing Alzheimer's disease. Again, for ever versus never, current users, ever versus never, ever versus never, ever versus never. The means are all on this side of the curve. There are a few that cross in terms of confidence interval that cross, but especially some of the later studies, strong suggestion that estrogen may be helpful in these observational studies in older women. There was some clinical trial evidence. A very small trial back in '97 suggested that estrogen was beneficial. Again, green is placebo, blue is estrogen. Looking at the percentage of subjects who improved, over 80% of the subjects improved. Only 20% had no change. However, people on placebo, 50% had no change, 50% actually got worse on placebo. Again, small subjects. Let me see. In addition, further clinical trial evidence suggested that estrogen decreased the age at onset of Alzheimer's disease. So if you're on estrogen, the age at which you start to have Alzheimer's disease seems to be less. And you can look at, these are survival curves. They're never on estrogen, much earlier onset, and much more rapid progression in terms of numbers. Here is the less than 1 year of estrogen use, and then these folks were on greater than 1 year of estrogen use. Now, what's the controversy? I'm showing you all this data. Well, recent study out of JAMA just last month, and I'm waiting for my slide to get made on that, showed that in a clinical trial that estrogen did not make any difference in the development of Alzheimer's disease as a treatment. So these are people that they took who already had Alzheimer's disease and looked at their cognitive decline over time. So estrogen as a treatment for Alzheimer's disease seems to have not been of benefit. Again, part of the problem for me with that study was, again, it was a small sample, about 123 subjects. Not a badly done study. I thought it was a nicely done study, but the degree of change they were looking for, they're looking for a 29% difference in score, and that's a pretty big difference. Even with some of the medication, we don't get that. So in terms of estrogen being a treatment, that's in question. However, again, the observational data suggests that estrogen may be a preventative agent. Again, the story on that is still waiting for the Women's Health Initiative and some of the other larger scale studies for their results to come out. One of the ways we think that estrogen is working on brain to do this is that we know that it stimulates the neurotrophic factors in the CNS, neurotrophic growth factor, protects neurons from beta amyloid toxicity. If you remember from previous lectures, I don't know if they've had previous lectures, beta amyloid is one of the contributing factors to the development of Alzheimer's disease. It maintains viability of neurons in cell culture, increases in regional, now that's pretty well proven. There's a lot of stuff from the National Institute on Aging showing that estrogen increases regional blood flow in patients with Alzheimer's disease. The thought is that if you increase regional blood flow, you stimulate those areas to be more active. And it also stimulates the production of some of the neurotransmitters such as acetylcholine and serotonin. So talking about Alzheimer's disease, if you lose estrogen, there is association of a decrease in cognitive function and possible increased risk of dementia. Potential therapeutic effects, again, conjugated equine estrogen, questionable. The Menopausal is one of the agents that was developed by the pharmaceutical markets. I think is helpful. I think the evidence is pretty clear on that, even up to 4 years now. There was a lot of stuff looking at NSAIDs. I think that's probably plus minus at this point. There's evidence now that suggests that NSAIDs, anti-inflammatories, don't have much of an effect, but early studies did say that they may be doing something, as well as vitamin E. I would say probably the cocktail that people are still using are the conjugated equine estrogens with donepezil with vitamin E, a sort of an attempt to treat this dreaded problem. Another issue, colon cancer, hormone replacement therapy and colon cancer. Third leading cause of cancer incidence and cancer death in women. The peak rises at age 40. It's more common in women than men. Okay, that's something that most people don't know. About 50,000, almost 50,000 new cases by 1997 estimates. Again, looking at estrogen as prevention of colon cancer. Again, this is our relative risk line again. See, most of the studies looking at 1, 2, 6 to 10, 11 years of estrogen use seems to suggest longer estrogen use gives you better prevention against colon cancer. In addition, estrogen reduces mortality by up to 50% from colon cancer. There's data that suggests that. And we'll talk about treatment a little bit later. Another one, age-related macular degeneration. It's probably the leading cause of blindness in the United States. Okay? Not the leading cause of blindness in the world, the leading cause of blindness in the United States. 60%, 70% new cases. Why is it so bad? Once you get it, there's really no therapy. The ophthalmologist can laser your eyes, but you know, the part he lasers to get rid of it is dead. You're not going to see from that part of the retina. It's often asymptomatic. The pathogenesis is really not known, although there is an increased risk if you're a smoker. I'm going to show you some of the same protective effect of estrogen. This is, again, observational data from the, actually this is the first really large study looking at age-related macular degeneration ever done. And this is observational data. This is backed up by the Beaver Dam study, which was probably the best study of this that was done. Looking at estrogen use, comparing estrogen use to controls, you can see that there's a risk reduction compared to never, from about 30% to about 60% for current users. Got to caution you though, very few subjects in that current user group to make these comparisons. So there's a suggestion from the observational study that may be beneficial. Well, now that I've talked about all these things, why isn't estrogen in the water? Right? It should be in the water supply if it was that great. It stops cardiovascular disease, stops osteoporosis, it stops age-related macular degeneration, stops colon cancer. Everybody should be running out sucking up estrogen, right? Well, it has risk factors. And one of the things that concerns most folks is this risk factor of breast cancer. Now, in fact, I'm going to show this slide first. If you look at the relative risk of breast cancer estrogen use, probably goes anywhere from former users of probably 1.7, which is about a 7% increase in relative risk, to current users somewhere around a 30% increase in relative risk. Now, there was a whole lot of hoopla recently about the journal article. Didn't surprise me at all, because I knew from probably 94 data that it was about a 30% increased risk. Now, there's some later data that came after that said it may have been as low as 3% or as high as 12%. But I think it's somewhere between the 7 and 35% range. And when I counsel my patients, I usually talk to them about the 30% increased risk. And I put that in perspective. First pregnancy, if they were late having their babies, they probably have a 40% increased risk on the same, that's relative risk on the same scale. If they're fat, probably a 40% increased risk. If they're a college graduate, probably the same increased risk. I don't know how many people are going to stop their daughters from going to college so they don't get breast cancer, but it's the same kind of risk that you see from observational data for breast cancer. So you need to put it in perspective. Now, in terms of counseling women, there was a whole lot of debate. I was just at a conference. There was a whole lot of debate whether or not women who either had breast cancer and women who are put on hormone replacement therapy really are at risk for developing breast cancer, even with the data I just shared with you. The thinking being is that if a woman has breast cancer in her late 20s, early 30s, and now she's 50, and you think about hormone replacement therapy, should she be started? The thinking has been is that she's getting her natural estrogen from her body for 20 years. If estrogen was going to cause you to have a breast cancer or recurrence, it would have happened. Okay? However, for the older woman, the woman who develops her breast cancer postmenopausally, I think there's a difference there. And no one really knows the true answer to that. Although there's some suggestion that unless the breast cancer is estrogen receptor positive, she may do okay with hormone replacement therapy. Part of the problem comes in is that if she started on it, especially there was some talk about being started on something like Raloxifene versus conjugated estrogen, will she lose the benefit from some of the chemotherapeutic agents like tamoxifen, for instance, as a treatment for her breast cancer? So a lot of this is out there and controversial. I think you need to consult the women, counsel them about their genetic factors, the issues of atypical hyperplasia, putting them at risk. There is data that says that survival is actually better for patients who were on hormone replacement therapy at the time that breast cancer was diagnosed. Now, I don't know what kind of consolation it is for a woman who be diagnosed with breast cancer, but there is data that suggests that they have probably a 20% better survival if they were on hormone replacement therapy. What about the other big risks? Well, I think we're pretty convinced now that endometrial cancer, there's about a 5-time greater risk of endometrial cancer for women on estrogen therapy without something to slough off her endometrium. You get probably equal risk for women who are, if you add progestin. So that risk goes completely away with the addition of progestational agent, so she sloughs off the endometrium. We're also pretty sure now that venous thromboembolism, there's an increased risk of that as well. Again, this is our relative risk line. You can see here, latest data all suggesting that current use of hormone replacement therapy increases your risk probably in the area of 2 to 5-fold increased risk of venous thromboembolism. And of course, if you increase venous thromboembolism, you increase the risk of its deadly complication, and that's pulmonary embolism. Relative risk probably 2.1% for women who are on hormone replacement therapy. So now that I've tempered my previous enthusiasm for hormone replacement therapy, what do you do? Well, you got to remember that there's going to be more selective estrogens. We already talked about estrogen being good for the heart, being good for the, well, there's no bones here, but teeth, being good for the brain, good for the colon, good for the urogenital tract, but it does have effects on the breast and blood clots in the legs. There's selective estrogens that target the good effects, some of the heart effects, some of the bone effects, while not giving the effects on the breast. Those may be the answer, perhaps not. But for what we have now with the conjugated equine estrogens, these are some of the things you need to be thinking about. If the woman comes in with symptoms, hot flashes, sleep deprivation, atropic changes, estrogen replacement therapy is indicated. Okay? Not the SERMs, because if you put someone with hot flashes on Raloxifene, like the doctor did to my mother, we won't go into that, she's going to get more hot flashes. And she's going to be wondering, why am I having hot flashes? Well, you're on a medication that's actually going to make you have more hot flashes. So you need to be doing the conjugated equine estrogen or one of the other estrogen preparations, not one of the serums. If they have pre-existing conditions that put them at increased risk, they have a first-degree relative that fractured their hip, okay? They're at risk for osteoporosis. They had a father that dropped dead of a heart attack at the age of 50. They're at increased risk. They have a mother who also while breaking her hip, suddenly had Alzheimer's disease at the age of 70, okay? Those things will make you look long and hard at using hormone replacement therapy. Now, if she's asymptomatic, healthy, exercising, happy, then you have to consider the risk-benefit ratio in those folks. And in those people, you need to weigh these benefits against these risks. Okay. Need to counsel them about hormone replacement therapy, talk about those benefits, and talk about the contraindications that we just talked about. Address concerns and misconceptions. A lot of the women that I talk to think that as soon as they swallow that estrogen pill, they're going to develop a breast mass because of the media. You need to put that risk in perspective and remind them that the number one killer, the number one risk of death, is really cardiovascular disease. If you take all the risk and weigh them against all the benefits in an asymptomatic woman, the fact that there's such a high prevalence of coronary artery disease in older women, hormone replacement therapy still comes out to be effective from a risk-benefit standpoint as well as a cost-benefit standpoint. Remind her about the benefits: decreases hot flushes, improves sleep, improves osteoporosis, plus minus improving CNS function, reduces genital urinary atrophy. I didn't put slides up about this, but there is evidence, probably related to its effect on bone, that it decreases the issue of tooth loss in older adults, reduces coronary vascular disease, plus minus reducing the risk of colon cancer, plus minus reducing the risk of age-related macular degeneration. Got to make sure you talk about the contraindications. Known as suspected pregnancy. Now, this would have been humorous a few years ago, right? But remember the lady in California who had the baby, got pregnant at 65. You know, so you got to think about that. Known as suspected breast cancer. If there's a breast mass, I'm chicken. I probably wouldn't put them on a hormone replacement therapy. There's any estrogen-dependent neoplasm. Okay? If she has undiagnosed abnormal uterine bleeding, okay, if she's still having periods and she has abnormal cycles, you need to think about what this means. If she has active thrombosis or thromboembolic disorders. Now, we used to say it had to be active. I would submit that if she has a history of venous thromboembolism, that now puts her at an increased risk. Maybe not be an absolute contraindication, but it's certainly something that would put them at increased risk and would make me not start hormone replacement therapy. If they choose not to take hormone replacement therapy, think of other options. Okay, think of other options. Vitamin D, calcium. If she has osteoporosis, maybe you need to get something to evaluate her bone mineral density. If she has coronary artery disease, you may need to lower her lipids, have her on aspirin. Okay? So there's other therapies that you need to still use. You can't just say, oh, you don't want hormone replacement therapy and send her out the room. Misconceptions you have to fix. You need to talk about the risk of breast cancer. Again, probably the biggest one. The issue of DVTs. This is one of my favorites. It's not a natural product. Now, the people I talk to at these conferences all talk about people talking to them about, oh, they want to take natural products. I have never had a woman not want to take Premarin because it wasn't a natural product. And in case, for those of you who don't know, Premarin stands for pregnant mare's urine. Okay? It comes from pregnant horses up in Canada somewhere that they make urinate in the cup. Now, I guess I could, if I was in California somewhere, I guess I could have someone who would not want to use Premarin because they say they make the horses stay in the stable and pee in a cup and cruelty the animal deal. But again, I've never had that happen. So I conceivably, you know, that's the issue. Hair loss is not an issue. You don't lose your hair when you start estrogen. I have not had any patients really complain of headaches or migraine on it. Another big thing is the resumption of menses and fertility. Let me talk about that one for a minute. If you give just estrogen, or you give estrogen with progestin in a cyclic fashion, that is, you give estrogen for 15 days and then progestin for 10 days, they will have a period and they will bleed again. Now, I am told, I cannot speak from personal experience, but I am told that most older women do not want to have periods again. Okay? What I let them know is that I put them on a continuous progestin. So they get estrogen and progestin continuously. There was a whole lot of debate whether or not that strips the effect of estrogen. I think for coronary vascular disease as well as osteoporosis, the evidence is clear. It does not strip that away. And what will happen, they will have spotting, and usually that will all go away in about 2 months. And they won't have really any bleeding after that. So that's usually what I'm doing, and that's why. Of course, you need to do your regular physical exam, an evaluation. If she accepts it, if she's had a hysterectomy, then you don't need to put her on the progestin because she's not going to have a uterus to worry about endometrial cancer with. If she has a uterus, you do need to add a progestin to the regime. Again, I usually use continuous regime versus a cyclic regime. For a woman who's perimenopausal, and this is the woman who's not completely gone through menopause, and menopause we define as the cessation of periods for at least a year. Okay, so she's having abnormal periods where she goes 3 months as a period, goes another 3 months as a period. So abnormal periods. These are the women between the ages of 40 and 50. Those are the folks that I tend to be thinking about either low-dose oral contraceptive pills, especially managed in menopausal symptoms, or cyclic hormone replacement therapy. They tend to get pretty miserable if you start them on continuous because it's a little high. They get a little more nausea. So I tend to go with the cyclic hormone replacement for those patients, and then they have a regular cycle. If they refuse, you need to know why they're refusing and make sure you've cleared up any misconceptions. And there's other things that you need to also make sure they do. If they have heart disease, statins, antioxidants, aspirin are at risk for heart disease. Statins, antioxidants, aspirin, diet or exercise. Stop smoking. That's probably the number one thing you do. You get benefits all the way up to 90s. Weight control, control of hypertension, control of diabetes. For osteoporosis, vitamin D, calcium, exercise. They don't want to take hormone replacement therapy. There's bisphosphonates and Raloxifene. So in summary, I think I saved a little time on this. Hormone replacement therapy is the most comprehensive therapy for women's health. For most women, it's appropriate. And for those who you decide it's not appropriate because of the side effects or the risk, or they just won't accept it, you need to be thinking about other options for treating them and preventing some of these illnesses. And that's it. If you have any questions, you can entertain them now. Okay. How many of y'all practice clinically? Oh, so this should be a big issue, right? You see a bunch of older women.
Well, I work at the VA, so we see only the male because it's very few.
Well, you should tell them. See, I got to talk about androgens and osteoporosis. Are y'all all VA folks?
Most, yeah.
I just started it. I've done a lot of this.
All right, so you know the story. Yeah, but when you get a woman, think about it. All right, so.
Yeah, everybody's into the plant products now.
Well, you know, that's an interesting point. The whole issue of phytoestrogens. My reading of the literature, apparently, unless you're on what they call the Asian diet, where you're taking the soy products as the soy protein, the phytoestrogens probably don't do a lot. You know, the issue of the isoflavonoids, and it was, health food stores are just selling these little isoflavonoid capsules. Apparently, the isoflavonoid capsules do not do anything for osteoporosis or for menopausal symptomatology. You need the protein itself, the soy protein, with the isoflavonoids to get the effect. So most of the people in the field are recommending that they go to the Asian diet where they eat, soy. Now, I think that's great if you like soy. I hate soy. So, for my,
Need any progesterone, I mean, how much estrogen?
that's a highly debatable. I don't think we know the answer to that.
Yeah, that's what I keep telling them, that I'm not gonna even want to do that.
Yeah.
Because
I-
you take this phytoestrogen, I don't know how much you're getting, I don't know if you're getting any progesterone.
Right. The last time I looked at the literature, there does not seem to be the effect on the uterus from phytoestrogens that you see in conjugated equine estrogen and other estrogen pills. So I feel relatively safe with that, but I think that it's certainly not clear at all.
What about the product called Romance, which is a pill that is made out of the phytoestrogen?
Right, that's one of the isoflavonoid pills, and again, you really can't. You don't have any beneficial effect because you need to have the proteins with it for that to work. But there's going to be data coming out on some of the new phytoestrogens as well. There's a study that's with the Women's Health Initiative, because we have a dietary component of that as well, that's going to be looking directly at the impact of phytoestrogens. So there's going to be a lot more answers in the next 4 years. A lot more answers.